Thank you for joining. We would like to welcome you to our annual CDC and Federal Office of Rural Health Policy webinar celebrating U.S. Antibiotic Awareness Week and National Rural Health Day. This year, we are also partnering with the Agency for Healthcare Research and Quality to showcase how the AHRQ Safety Program Toolkit can be implemented in critical access hospitals. My name is Melinda Newhauser, and I am the pharmacist and acute care lead for CDC's Office of Antibiotic Stewardship, and I'll be the moderator today. And at this time, I would like to introduce our speakers. Very thrilled to be joined by Natalia Vargas, who is program lead for the Medicare Beneficiaries Quality Improvement Program in HRSA's Federal Office of Rural Health Policy, who will discuss the recent efforts to support improvements in antibiotic use in rural facilities. Next, we'll discuss the 4 moments of antibiotic prescribing in critical access hospitals with Dr. Melissa Miller, who is a physician in the Division of Healthcare Associated Infections in the Agency for Healthcare Research and Quality. Dr. Pranita Tama is infectious disease physician and director of the Pediatric Antimicrobial Stewardship Program at the Johns Hopkins Hospital. And then Dr. Sarah Cosgrove is also an infectious diseases physician and director of the Adult Antimicrobial Stewardship Program at the Johns Hopkins Hospitals. At this time, I would like to introduce Natalia to provide her presentation.
Thank you, Melinda. I really appreciate the introduction and would like to thank CDC for the opportunity to be here today. I will be presenting our recent efforts to support improvements in antibiotic use in rural facilities. So my goal with today's presentation is to set the stage for what you will hear next from the presenters that we have lined up today. And we have 3 objectives to cover in this portion of the webinar. And that is, first, I would like to review the national reach and overarching goals of our Medicare Beneficiaries Quality Improvement Program, and then provide an overview of the healthcare delivery and quality improvement context in rural facilities. And then end with a short discussion on how we aim to collaborate across levels of the healthcare system so that we can reach these program goals and improve quality of care for rural populations. This is just to give you a snapshot of what it's like to serve these hospitals across the country. We have, where you see on the right side, all of those dots, the colored dots on the map, are the critical access hospitals that we serve. They comprise over 75% of all rural hospitals in the United States. We, through MBQIP, are able to support these hospitals in providing high quality care to rural populations. These small hospitals are limited to only 25 beds. So unlike traditional hospitals paid through the prospective payment system, Medicare pays critical access hospitals based on each of the hospital's reported costs. Therefore, with this context, you can see that, we try to really provide the support for these small rural hospitals to report measures so that we can use those measures to improve quality of care for populations. The primary goal of our program is to enhance the reporting of quality data and then have the hospitals use that data for quality improvement activities and support quality improvement measurements and quality improvement activities across all of those hospitals. We have about 1,350 hospitals that are currently participating in our program. And through our program, we established this national tracking system for the first time so that these hospitals that voluntarily report quality measures to CMS are able to be supported through our program and have additional access to funds that support quality improvement activities. So we work at the intersection of various levels of the healthcare system, the national, the state, and facility levels. And antibiotic stewardship is one of those successful examples of how we have used one of the measures to enhance reporting that then drives improvements at the local level, at the hospital level, by expanding those activities for quality. So the healthcare delivery context in rural facilities is that essentially we have a mandate to serve over 60 million people with very little resources. And unfortunately, these are competing priorities that we have. Access, quality, and costs are always competing in rural settings. So what we hear most in terms of challenges from our hospitals is that there is scarcity of infectious disease physicians and pharmacists. There is a little bit of lack of provider engagement in antimicrobial stewardship due to the competing priorities that I mentioned. We have also come across deficiencies in staff understanding of antibiograms, sensitivity reports, drug classes, how to use antibiotics properly. And also we have limited capabilities of EMRs to mine data for QI. Despite all of these challenges, we have some real implementation outcome examples here that I've outlined for you. We are really focused on pushing the accountability for optimizing antibiotic use in critical access hospitals and increasing the number of interventions at the hospital per week. Some hospitals have also reported that through the implementation of antibiotic use focused activities, they have reported decreases in cases, but also they have decreased the costs of purchasing antibiotics at the hospital. Underpinning all of these efforts is actually the collaboration approaches that they have used for antibiotic stewardship, such as sharing education, resources, and tools to better equip the providers. And that strategy has been one of the most successful ones to be used in critical access hospital facilities to overcome those challenges and support those implementation outcomes that I have outlined above. So with that is of key importance to our program that we better collaborate across the levels of the healthcare system. And that is what brings this presentation today. As you can see, we have joint efforts with our CDC colleagues, with our Agency for Healthcare Research and Quality colleagues, to really address the improvement goals that we have in our program that we see, through this chart. You can see there is a macro level, a meso level, and a micro level. This is adapted from academic pediatrics journal article. And basically what it does is that it shows the connection for why it is important to connect those dots across the systems. We set priorities at the federal level, but we must work together in order to reach those goals. We have to better understand the role of managed care delivery at the meso level in order to really impact what happens at the micro level, to provide evidence-based treatments and services that support patient care and improve health outcomes in rural areas. So as we look ahead in our program goals, we are hoping to identify other rural relevant measures that in order to establish a curated measure set. One of the broad priority areas that we have is actually patient safety. So the work that we're doing in this space is very important. We also hope to continue supporting critical access hospitals to report measures that align with CMS IPP rules. And one of the priority areas will involve antibiotic use. We also hope to continue supporting the states in building capacity for conducting QI, building the work that states have completed so far as part of QI projects that they're implementing, and co-designing with the critical access hospitals, including antibiotic stewardship, and also integrating a systems level approach to the work that we do, to the strategies that we implement at the program level, which involves this type of collaboration today. So today I'm just really pleased to be here in celebrating what we call National Rural Health Day, that is actually tomorrow. And the theme for this year is driving change, going the extra mile. And that's what we're hoping that this presentation brings to you today, is just driving changes in critical access hospitals in a way that helps contextualize the care that we support in these rural communities. So with that, I will leave my contact information here, and I will pass it on to my colleague at AHRQ, who will be speaking and introducing herself next. So Dr. Miller, thank you.
Thank you, Natalia. Thank you both to HRSA and to CDC for having us here today. We're looking forward to sharing our toolkit and work with you. So today we're going to review the overarching goals of the AHRQ safety program for improving antibiotic use. We'll provide an overview of the safety program and review the findings from the one-year acute care AHRQ safety program, and discuss how to apply the 4 moments of antibiotic decision-making in clinical practice using a case-based approach for community-acquired pneumonia and urinary tract infections. So first, to review the overarching goals. Next. Antibiotic stewardship or antibiotic stewardship programs, or ASPs, have traditionally used a top-down approach to improve antibiotic use in acute care settings. For example, an administrative decision to use one antibiotic versus another, or a service that guides the antibiotic use, such as a traditional antibiotic stewardship program. Our AHRQ safety program for improving antibiotic use challenges this approach by equipping frontline clinicians with tools to incorporate stewardship practices into their daily decision-making. So the AHRQ safety program for improving antibiotic use aimed initially to improve antibiotic use in acute care, long-term care, and ambulatory care settings in a phased approach. What we're presenting today represents the experiences of the first large cohort of over 400 acute care hospitals, including critical access hospitals. The goals were to assist facilities with establishing or strengthening ASPs, to provide frontline clinicians with tools to incorporate stewardship principles into routine decision-making by underscoring the importance of communication and teamwork around antibiotic prescribing, and to equip frontline clinicians with best practices in the diagnosis and treatment of common infectious processes. So next, I'm going to hand it over to my colleague, Dr. Pranita Tama, to provide you with an overview of the safety program.
Thanks so much, Melissa. And I'm excited to talk a little more in depth about the acute care portion of the AHRQ safety program. So just very briefly, this was a one-year program. It occurred in the calendar year 2018. And the goal was to include at least 250 acute care facilities across the United States. And recruitment efforts included social media campaigns, engagement of federal partners, including the CDC and HRSA, and professional societies. And we invited either entire hospitals, which was generally the case for critical access hospitals, or individual units within a hospital to participate. And Sarah Cosgrove and I delivered all the webinars. It was usually about 2 webinars per month, each delivered about 3 times to accommodate different work schedules and time zone differences. And we invited all members of the healthcare team to participate, including physicians, mid-level providers, pharmacists, nurses, and anyone else who was involved in the process of antibiotic decision-making. We also included 2 office hours every month, where participants had the opportunity to ask questions about implementing stewardship programs, or even just management questions related to particular patients. And we were very fortunate to partner with quality improvement experts that came from Health Quality Innovators, Health Services Advisory Group, and Stratus Health. And one quality improvement expert was assigned to each participating hospital to assist them with some of the day-to-day stewardship implementation work. So I'm going to go a little further into what actually took place during the one-year period. And fortunately, AHRQ did a very nice job on their website of developing a toolkit where the material can be accessed, so that even for sites that didn't participate in this one-year program, they would have the ability to access all of the content developed for the program. And on the website, there's some guidance on how you could implement the toolkit locally to emulate the one-year program. So just very briefly, there were 3 general domains as part of this acute care safety program. The first was assisting sites with developing stewardship programs. Some sites did already have a stewardship program that was maybe in its early phases, and we assisted them with how they could sort of take it to the next level. Part of this involved identifying a leadership structure. Ideally, we preferred a clinician and a pharmacist lead, not necessarily trained in infectious diseases, because of course that's just not feasible in many sites, and how they could identify senior leadership to garner the support amongst other healthcare practitioners within that facility. We also assisted them with identifying how to develop metrics, to collect data for metrics, which I'll talk about, and to use these metrics by tracking them over time to guide intervention. So for example, if you notice that vancomycin use is extremely high in an ICU, what kinds of interventions can you think about to help reduce that use? The second main domain was trying to develop a culture of safety around antibiotic prescribing. We realized that a lot of times there's a social etiquette involved around prescribing, where perhaps one prescriber starts an antibiotic, another clinician comes on and might feel strange stopping an antibiotic if a colleague started it, because it might be deemed disrespectful. Or perhaps during clinical rounds, a physician is rounding, discussing the patient, and a nurse might feel a little, might not feel as empowered to mention that the patient is still on vancomycin. Is this really still necessary? So we wanted to help with improving teamwork and communication between healthcare providers, as well as between healthcare providers and patients and families who might be expecting an antibiotic. And finally, the third domain dealt with teaching frontline providers with learning best practices in the management and the diagnosis and management of common infectious diseases syndromes. And we decided to focus on syndromes and not antibiotics, because clinicians are generally much more excited if you say, would you like to learn about the latest data in managing community-acquired pneumonia versus would you like to learn how to use vancomycin more appropriately? And for all of the syndrome-based content, we organized the material using a framework we developed as part of this program called the 4 Moments of Antibiotic Decision Making, which I'll summarize. So this is a snapshot of from the AHRQ website. In the develop and improve stewardship content that's really targeting the stewardship leader. So again, ideally a clinician and a pharmacist, a physician, and if a physician's not available, a mid-level provider like a nurse practitioner or physician assistant, along with a pharmacist. And we have content in how to develop the program, how to make effective behavior changes around prescribing, and after the program is developed, how to sustain stewardship activities so that this program will continue to exist and be impactful. And these content are available as PowerPoint slides on the website. There's also what we call a facilitator guide, which includes a detailed script for each slide, so that the content can be used locally. In terms of the developing culture of safety around prescribing, there's 4 targeted PowerPoint slides with facilitator guides for each of these, and these are targeting mostly frontline providers. For each of these, we used case-based approaches because we think that that's probably most engaging to healthcare providers. And finally, for best practices, as you can see here, we target a variety of syndromes that we think are common problems both in large academic facilities as well as small critical care access hospitals. And for all of these, again, we have slides available as well as the facilitator guide. And we also have several other types of content available, which I'll show you in the next few slides. But for all of these best practices topics, we use what we call the 4 moments of antibiotic decision making. So these are the 4 moments when we think clinicians should review when deciding if a patient needs antibiotics and if antibiotics need to be continued. So very briefly, the first moment asks, does my patient have an infection that requires antibiotics? And this might just be stopping and thinking about the patient. Maybe the patient has a cough, Maybe they're having a little bit of chest pain, but is this a pulmonary embolism? Is this congestive heart failure? It doesn't necessarily have to be bacterial pneumonia. So it's really asking clinicians to stop and think about, is it more likely than not that this patient has a bacterial infection? The second moment has two questions. Have I ordered appropriate cultures before starting antibiotics? For example, do I need blood cultures? Do I need urine cultures? Do I need a sputum culture? And the second question asks, what empiric therapy should I initiate? And for each of the infectious syndromes, we include guidance on what we would consider empiric therapy for your routine patient. And then what about patients who might have a severe penicillin allergy, who might, maybe there's concerns for MRSA or concerns for Pseudomonas. And in those patients, the empiric therapy regimens might be different. The third moment has three questions after more clinical and diagnostic data are available. And these include, can I stop antibiotics, particularly if cultures are negative and an alternative diagnosis has been established? Can I narrow therapy or change from an intravenous to an oral agent? And finally, the fourth question asks about the duration of antibiotic therapy. For all of the best practices topics, we include evidence that supports what the available data suggests in terms of effective durations of antibiotic therapy. And then again, for each of the topics, as an example, we have what we call a one-page document that summarizes some of the data. These are editable on the website so that local sites can include recommendations here and make these their local treatment guidelines. Alternatively, you could delete these sort of place local recommendations here sections and post these in common work areas, send them as emails or other ways to disseminate this knowledge between the healthcare providers in your facility. We also include commitments posters on the website, and we suggest that people put the pictures of providers, their signatures, maybe pictures and signatures of leadership. And this is meant to show that to patients, as well as to just all healthcare providers within the institution, that you're a facility committed to the judicious use of antibiotics. And similar to this commitment poster, we also have posters with the 4 moments, screensavers for the 4 moments that are available on the AHRQ website. And then another document we developed that we thought was particularly helpful in settings like critical access hospitals were what we call the team antibiotic review form. So the goal with these forms would be every month we would ask sites to retrospectively pick 5-10 patients who are receiving antibiotics, and as a group to go through these questions that use the format of the 4 moments, so that you could look for areas for maybe where there should be improvement for the next patient who started antibiotics. So it might be caught that perhaps vancomycin was continued for too long, or a duration longer than the evidence suggests is necessary might have been prescribed. And the hope would be that as a group, again, including nursing, pharmacists, physicians, and anyone at a team meeting, that lessons could be learned to improve care for the next patient. So for the sites that participated in this 1-year program, we requested that they submitted antibiotic use data as days of antibiotic therapy per 1,000 patient days, and they submitted these data on a monthly basis. We also requested they submitted C. difficile lab ID event per 10,000 patient days. So basically, this is looking for if a lab test indicated positive C. difficile testing. Of course, this is not a perfect proxy for clinical C. difficile infections because some patients might be colonized, but we thought that this would still be helpful to get a sense of if we could impact C. difficile rates by reducing antibiotic use, or really optimizing antibiotic use, I should say. And then we requested up to 10 team antibiotic review forms per month. For some hospitals, particularly critical access hospitals, they might have actually had less than 10 patients a month on antibiotics. And of course, that was perfectly acceptable too. And for all sites, and we talk a lot about on the website, how to collect the data, how to report data to clinicians within your institution. But what we would do with the program was feedback quarterly reports, so you could compare yourself over time and also compare yourself to like facilities. So for example, for critical access hospitals, we compared them to other critical access hospitals, and of course, not large academic medical centers. I'll move on to very briefly summarize the findings of the project before I hand it over to Sarah Cosgrove. But there were 402 hospitals that completed the one-year safety program, over 90% of facilities that started the program, which we were very happy to see. And for those that weren't able to complete it was often because they had staff turnover and didn't have the resources to stay engaged. In terms of the types of hospitals that participated, about 20% were critical access hospitals, and about 40% of hospitals had less than 100 beds. So it was really a variety of types of hospitals that participated in the program. And what we saw was that antibiotic use decreased in that first quarter. And in this first quarter, we were actually relatively aggressive with the number of webinars and engagement we had with sites. And then after that, antibiotic use plateaued and basically stayed relatively consistent. We actually were able to compare these data with data from Premier, which included a large number of hospitals not participating in the program. And basically that data suggested that antibiotic use in non-participating programs started off high and remained relatively consistent throughout the 1 year. So they didn't have this sort of drop in that first quarter. And obviously it's not a perfect comparison, but just gives you a sense of what was happening nationally in other institutions at the same time. We did find that antibiotic use significantly decreased when we looked at the data in various subgroups. And I highlighted in red here critical access hospitals, where we did see a significant reduction in antibiotic use. And also across the cohort, we saw a significant reduction in C. difficile lab ID rates. So I'll hand it over to Sarah. And before I do so, again, I just want to stress that we really do encourage people to go to the AHRQ website to look at the content of this program, because I really do think that there's this can be sizable, scalable for all institutions, including critical access hospitals. So thank you very much.
Thanks, Pranita. We'll start the last portion of this with a clinical case and then basically go through this case showing how you could apply the 4 moments in everyday decision-making around antibiotics. This is a case of a 54-year-old man with diabetes and hypertension who presents with 2 days of fever, a cough, and left-sided chest pain. He's febrile, his blood pressure is fairly normal, but his heart rate is elevated and his respiratory rate at 24 is certainly elevated. He has a normal oxygen saturation of 95% on room air. Otherwise on exam, he is tired appearing and has crackles over the lower left lung field. So going through the 4 moments, remember that the first moment is, does my patient have an infection that requires antibiotics? So thinking about this patient, he meets a lot of criteria for community-acquired pneumonia, and therefore in him, CAP is likely. But if some of this presentation were slightly different, he might actually have something that is not community-acquired pneumonia and may mimic some of the signs and symptoms of community-acquired pneumonia. So we always say, think about other potential causes of someone's presentation. And just some examples of things that would also be considerations on the differential here are viral respiratory tract infections, aspiration pneumonitis, chronic obstructive pulmonary disease exacerbation, asthma exacerbation, congestive heart failure, and pulmonary embolism. I'm not saying that that's what I think he has, but a lot of times people present with symptoms that are a little more nonspecific than what he has. And so these other items should certainly be on the differential, and the majority of them do not require antibiotic therapy. And I think our next steps in management of this patient would be to obtain a chest x-ray. And it's also important to know, while you're thinking about does a patient need antibiotics or not, that if there's no infiltrate on a chest x-ray, that the patient in general is much less likely to have community-acquired pneumonia. So moving on to moment 2, remember moment 2 has 2 questions. Have I ordered appropriate cultures before starting antibiotics? And what empiric therapy should I initiate? Remembering, of course, that empiric therapy ideally should be based on local empiric treatment guidelines that have been developed by the stewardship program in conjunction with frontline providers. So first, with diagnostic testing in community-acquired pneumonia, a sputum, gram stain, and culture is recommended if a patient is able to produce sputum. And blood cultures are really, at this point, not recommended for all patients. They used to be part of a core measure that led to people getting blood cultures all the time in patients with community-acquired pneumonia. That is no longer a requirement. However, if the patient is quite ill, or they have any abnormal chest imaging findings, such as a lung abscess or a parapneumonic effusion, then it's reasonable to consider blood cultures. But in the average patient presenting with CAP, blood cultures are likely to be a very low yield. It also can be useful to obtain a respiratory virus panel because that can be an alternative explanation for a patient's clinical symptoms, particularly during respiratory virus season. And, you know, in institutions that have the strep pneumo urinary antigen test, that can be considered. Many institutions don't have this available. We actually do use it in our institution because we find that it can be helpful, if positive, to say that the patient has pneumococcal pneumonia and not some other kind of pneumonia, and that allows us to comfortably narrow antibiotic therapy to amoxicillin. And then again, on the theme of urinary antigen tests, if Legionella urinary antigen testing is available, it can be considered for patients with moderate to severe symptoms, people who smoke, immunocompromised patients, or patients over 50 years of age. So remember, the other part of moment 2 is empiric therapy. Empiric therapy for community-acquired pneumonia in the United States is largely driven by existing guidelines from the American Thoracic Society and the Infectious Diseases Society of America. And these recommend coverage for typical bacterial pathogens such as Streptococcus pneumoniae and Haemophilus influenzae. And the US guidelines also suggest coverage for atypical organisms such as Legionella. So regimens to consider are ampicillin or ceftriaxone as your beta-lactam agents, plus either azithromycin or doxycycline. The guidelines will tell us that there is more evidence for azithromycin than there is for doxycycline. However, many institutions preferentially use doxycycline because it is less commonly associated with Clostridium difficile infection than other antibiotics. In general, and as part of the safety program, we discouraged use of fluoroquinolones for the majority of patients, not just for patients with community-acquired pneumonia. And one of the findings in our safety program was that the decreases in antibiotic use were driven by reductions in fluoroquinolones. So for community-acquired pneumonia, even though historically I think many providers have reached for fluoroquinolones because they think, oh, it's easier, it's just one agent. We really recommend, as do the guidelines, against these being first-line agents and instead limiting them to patients with severe penicillin allergies. And as I mentioned, you know, most antibiotics are associated with C. diff, but fluoroquinolones in particular can be associated with C. diff infections and other side effects such as prolonged QTC intervals, tendinopathies, altered mental status changes. And this is particularly an issue in the elderly population. So I really do try to avoid quinolones in that population. I think a common question that comes up is it okay to cover patients with community-acquired pneumonia with all those agents that we just discussed? Should we be concerned about patients' risk for methicillin-resistant Staph aureus or risk for Pseudomonas aeruginosa? And I just want to say, for both of these organisms, which are the source of much hand-wringing and worrying in the hospital, as we all know, that CAP is very unlikely to be caused by MRSA and very unlikely to be caused by Pseudomonas aeruginosa. And frankly, in patients who ultimately do have these organisms isolated probably didn't have what we would call community-acquired pneumonia. They probably had pneumonia that was associated with contact with some kind of healthcare facility. I think another interesting point for MRSA is that there have been many studies that both tell us it is uncommon as a cause of CAP, and then a large study that showed that empiric anti-MRSA therapy was not associated with reduced mortality in patients with CAP. So I think there's just a couple of considerations for when you might use this agent, and they include patients who present fairly ill and have a cavitary or necrotizing pneumonia on chest X-ray or chest CT, and in patients that have MRSA risk factors, perhaps if the sputum gram stain has gram-positive cocci and clusters on it. The standard CAP regimens don't include coverage for MRSA, so if MRSA coverage is indicated, this would be vancomycin, linezolid, or trimethoprim sulfamethoxazole. And then for Pseudomonas, again, I think I've mentioned now several times that Pseudomonas CAP is very rare. In general, you would think about it in patients who had a fairly severe underlying lung disease, such as bronchiectasis or severe COPD, where they have likely been exposed to multiple courses of different antibiotics over several years. And then the other groups of people who have this, in general, they don't have CAP. They have some kind of healthcare associated pneumonia. So recent receipt of broad spectrum antibiotic therapy, recent prolonged hospitalization, admission from a skilled nursing facility or nursing home, or people with significant immunocompromise. And of course, coverage for Pseudomonas would be with cefepime or piperacillin and tazobactam. So we'll move on to moment 3. And so this is a moment that should happen every day that a patient is on antibiotics. So a day or more has passed. Can I stop? Can I narrow? Or can I change from IV to oral therapy? And so for community-acquired pneumonia, there we go. Transitioning to oral therapy is recommended as soon as the patient is starting to have clinical improvement and able to tolerate oral medication. So in community-acquired pneumonia, there's no requirement for prolonged IV therapy. So when when their vital sign parameters are starting to normalize, it's perfectly reasonable to transition to oral therapy. We, in general, transition to an oral third-generation cephalosporin, or as I mentioned, if you know that the patient has pneumococcus in general, it's safe to transition to amoxicillin. I think we covered that. So now we can move on to moment 4. What is the duration of antibiotic therapy for my patient's diagnosis? And fortunately for community-acquired pneumonia, we now have multiple randomized controlled trials and observational trials that indicate that 5 days of antibiotic therapy is sufficient for most patients with community-acquired pneumonia. And this should really be the standard, 5 days. We should drill that into everyone's head, 5 days of therapy. There are, occasionally cases where someone has severely immunocompromised, has severe underlying structural lung disease, or had inadequate clinical response or ended up growing an organism that you weren't covering where you might prolong therapy to 7 days. But the vast majority of patients with CAP should be treated for 5 days. If you started a combination regimen with the beta-lactam and azithromycin, remember that you don't need to give more than 3 days of azithromycin. It has an incredibly long half-life. And so it's actually, even with 3 days, sticking around in that person's body for probably 10 days. So remember to encourage discontinuation of azithromycin after 3 days if it was part of the empiric regimen, unless the patient is diagnosed with Legionella, in which case longer courses of azithromycin would be indicated. Also, remember to remind patients that they may feel tired, they may have a cough that goes on for quite a few days after a bout with community-acquired pneumonia. and it's going to take a while for them to get better, but don't rework them up for this, by getting chest x-rays and more sputum, because chest x-rays can take a long time to improve. So it should be considered as part of the natural history that cough and fatigue can go on for a few weeks after a patient has community-acquired pneumonia, and is not a reason to prolong antibiotics. So I think we have time to run through quickly a second case, just to give another idea of how you can use the 4 moments. This is a case of a 31-year-old woman who is healthy and presents with dysuria, fever, rigors, and left-sided flank pain. She, also has evidence of being infected with a temperature of 101, low blood pressure, elevated heart rate, and is satting normally and breathing normally. On exam, she is ill appearing, but able to carry on a normal conversation. So for this patient, the first question is, does my patient have an infection that requires antibiotics? In this case, the patient has signs and symptoms that are concerning for pyelonephritis. So in this particular case, the answer is yes. But in general, for urinary tract infections, there are many situations where patients do not necessarily have an infection, even if they have abnormalities with their urine. So remember that foul-smelling urine, cloudy urine, or isolated mental status changes in the absence of other clinical symptoms of a urinary tract infection are not indications to obtain urine cultures. If a urine culture is obtained and comes back positive, it's always important to go back to the patient and ask about symptoms, because a lot of time in medical care, urine cultures get sent all the time, and then no one remembers why that urine culture was sent, and positive urine cultures can trigger antibiotic therapy when antibiotic therapy is not needed at all. So moving on to moment 2, have I ordered appropriate cultures before starting antibiotics, and what empiric therapy should I initiate? Just some more information about interpreting, sending and interpreting urinalysis and urine cultures. There are, in general, in labs, cutoffs for positive UAs, and so your lab might differ, but in general, this is usually considered greater than or equal to 10 white cells per high-powered field. In patients with very small numbers of white cells in their urine, a UTI is in general unlikely. In our patient with pyelonephritis, a urine culture should be obtained, but a lot of patients get urine cultures, as I mentioned, it's really important to look at colony counts in these urine cultures when assessing whether they are clinically significant. If patients do not have symptoms and have low colony counts, again, highly unlikely to be a urinary tract infection. And then with regard to blood cultures, most patients do not need blood cultures. Certainly patients with concern for cystitis don't need blood cultures, and patients being treated for pyelonephritis as outpatients don't need blood cultures. If patients are hospitalized for pyelonephritis, a urine culture is still the most useful culture, but if there's any concern about getting that urine culture, difficulty getting that urine culture, or if the patient has evidence of sepsis, then blood cultures should be obtained. So moving on to the empiric therapy part of moment 2, for patients being hospitalized with pyelonephritis, currently we recommend use of ceftriaxone if a patient has risk factors for Pseudomonas or structural or functional urologic abnormalities, then cefepime. And if patients have histories of extended spectrum beta-lactamase producing organisms, particularly E. coli, then recommend use of a carbapenem. For severe penicillin allergy, it can be either aztreonam or gentamicin. If you look at national guidelines for urinary tract infections, Quinolones and trimethoprim sulfamethoxazole are still high on the list for empiric treatment. These guidelines are now over 10 years out of date. And while fluoroquinolones and trimethoprim sulfamethoxazole have excellent kidney and urine penetration, the big issue with them is that we have seen increasing resistance, particularly in E. coli, over the past decade. And this is in many parts of the United States, although not in all of the United States. So if resistance rates are known to be low, ideally less than 10%, then these agents can certainly be considered for empiric therapy. The problem is in many parts of the country, the resistance rates for fluoroquinolones and trimethoprim sulfamethoxazole for E. coli are now, 30 to 40%. So moving on to the third moment, a day or more has passed. Can I stop? Can I narrow? Can I change to oral? In patients admitted with pyelonephritis, therapy should be transitioned to oral therapy again as soon as the patient is feeling better and whenever the patient can tolerate oral therapy. This is one situation where we actually favor use of quinolones. I know I always talk about not using quinolones, but because of their outstanding urinary penetration, I think they're very reasonable to use in step-down therapy for patients with pyelonephritis because you can give a pretty short duration of therapy. But it's important, whether you're using quinolones or trim-sulfa, to make sure that the organism is susceptible. If you can't use these agents because of susceptibility issues, then in general, we use oral cephalosporins. And then finally, the fourth moment is what duration of therapy is needed. In this case, durations for pyelonephritis. And as I mentioned, quinolones can be attractive in these situations because patients can be treated with 5 to 7 days of therapy. In contrast, we don't have clinical studies that support these short courses of therapy for other agents. So even for trim-sulfa, which again has excellent urinary penetration, we unfortunately don't have a lot of studies that say we can use these shorter courses of therapy. And then for oral cephalosporins, there probably is a bit higher failure rate for oral cephalosporins. And so if you're using them, again, 10 to 14 days of total therapy, of course, including the days that the patient received in the hospital. And, much like not repeating chest x-rays and sputum cultures in patients with the CAP, in patients who are recovering from urinary tract infections, they also do not need repeat urine cultures. So I'm going to sum up the presentation for all three of the speakers. And I hope that we have convinced you that implementation of the AHRQ safety program for improving antibiotic use was valuable and useful and associated with enhancing antibiotic stewardship programs and improving antibiotic prescribing. And I want to point out that 20% of the participating hospitals were critical access hospitals, and we did see reductions in antibiotic use in these hospitals. Because overall the amount of use is not as high compared to larger hospitals. This was not a significant finding, but the magnitude of reduction was actually greatest in critical access hospitals. So I think if we had had more critical access hospitals, ultimately, I think that finding would have been significant. And then finally, you've heard before, but I'll say it again, that the AHRQ safety program for improving antibiotic use Toolkit is available at the AHRQ website. All the materials that we've discussed today are available for download. Most of them are editable so that you can customize them for your site. If you're somehow also looking for materials for nursing homes and materials for outpatient care, we have toolkits with all these same features available for those settings also on the website. So thank you for your attention, and I think we have some time for questions.
Yes, thank you so much for all our speakers. And I could just listen to Sarah all day talking about clinical pearls for infections. So I'll actually maybe start with you, Dr. Cosgrove. In terms of, there's a question about the 3-day course of azithromycin for CAP. What dose is used?
It would be 500 for 3 days.
Okay, great. And in terms of the engagement for the office hours, just one of our audience members was curious of what the engagement was like for the office hours.
We had a good time on the office hours. It was actually it was really fun to do the office hours. I think that, and I don't mean to like toot our own horn or something, but I think that people were excited to have access to infectious disease stewardship physicians. And, I know that there are many places in the country that really don't have that access. And so it was really just a treat to be able to, just be there to answer anyone's question, because it could be anything. It could be programmatic stewardship stuff. It could be, I'm having this problem with this person. Can you help me solve this problem with this person? Or, just stuff about the evidence behind recommendations and so forth.
Yeah, absolutely. And getting some questions about using days of therapy per 1,000 patient days, particularly in the context of a small hospital, a critical access hospital, and some of the limitations. For example, one of our audience members is saying that one patient could really impact your days of therapy. And they were wondering if you had thought about other measures that might better capture this excellent work that you've done.
So I completely agree that I think that is a very challenging metric. It's actually a challenging metric for all hospitals, because even if you have tons of antibiotic use, it's actually hard for clinicians to understand. We've had this experience in our institution. We're like, well, your Vanco increased from this to this, and they're like, what does that mean? Why do I care if my Vanco increased from 500 days to 600 days? What does that mean? And so I think we all should be thinking about alternative metrics. Obviously those kind of metrics are helpful to stewardship programs to track things over time. But when we are trying to engage providers, I think it can be more challenging. I actually think that what providers respond to more is assessments of appropriate decision-making or adverse events. And so if you have the bandwidth to look at a sample of cases, kind of like we did with the team antibiotic review form, or, even if you say, every Friday, I'm going to look at everyone on antibiotics and just do an assessment. 30% of people were guideline non-compliant, 60% of people were guideline compliant. Here's some of the things I found. That I think is actually more valuable feedback to the front line than days of therapy per 1,000 patient days. And apologies to CDC, because obviously, that is the approach for large scale surveillance. But when we're talking to front line, they need something they can wrap their head around. And, another thing is, if you do have C. diff cases that you can review, we find that our folks really kind of like to hear about, assessments of how well they did with managing C. diff. And that covers both the diagnostic stewardship parts of the C. diff, like should the patient have been tested in the first place? It covers, were the antibiotics non-C. diff related that the patient was on appropriate, or did they contribute to the C. diff? Once they found out about C. diff, did they modify the antibiotics or stop them? And then even did they use the right approach with the treatment of the C. diff? So lots of stewardship stuff around C. diff.
Absolutely. Thank you. Along similar lines about really tracking antimicrobial use, we had an audience member ask if there's a comprehensive list of antibiotics on a spectrum of broad to narrow when this individual is doing audits, and if a physician changes the antibiotic, not a clear guidance in terms of if that was a deliberate move to more narrow spectrum. If you want to. I know Pranita too, you're welcome.
I can comment real quick.
Yes.
I think this is like the question of the century in some ways, because we talk about, narrowing, and it is like a core component of stewardship, but most of the antibiotics we use are pretty broad, when you think of what their potential impact is on the human microbiome. But in general, you can, I think, have your class of agents that have anti-pseudomonal coverage and have a goal to not be on those and to narrow to something else that doesn't have anti-pseudomonal coverage if they don't have Pseudomonas. I think that, for vancomycin, most of narrowing of vancomycin is stopping vancomycin. So if they don't end up having an indication to be on vancomycin, no MRSA isolated, no other thing that might need vanco, narrowing of vancomycin means stopping vancomycin. And, if you can get people on penicillin, that is truly a pretty narrow spectrum drug relative to everything else. Amoxicillin is narrower than late generation cephalosporin. So if you can get people on amoxicillin, that's good, but it's not crazy narrow. It kills plenty of gram positives and gram negatives. So Pranita, any other thoughts?
No, that's good. Happy to have you talk.
Okay, we have like a technical question here. What is the recommendation for the duration of azithromycin if a urine Legionella is positive?
Yeah, so there's not actually a recommendation because there's not been studies performed on the duration. What's kind of suggested and up to date and some other sort of review articles is somewhere in the range of 7 to 14 days. I think most people would probably treat till the patient's better and maybe a couple of days more and stop. Like Sarah, I always favor shorter durations whenever possible. So certainly if the patient is responding to therapy, I think a week is probably fine. If the patient's critically ill in the ICU, then maybe going to like 10 days or so might make sense. But there's not actually, unlike traditional CAP where there are very nicely done RCTs, that data is just not available with Legionella.
I think
of durations.
That you don't have to switch someone to a quinolone just because they have Legionella. That is, azithromycin and quinolones pretty much have the same activity. And so if you already have them on the azithro, you can stop the ceftriaxone or the amsulbactam and just keep going with the azithro.
Yeah,
that's one of my CAP pet peeves, when people switch to quinolones, then they don't need to switch to quinolones. So
Well,
child and babies considered. We do for the acute care program. I'm a pediatrician. We definitely, the guidance that's in there is very generalizable to both children and adults. And if there are exceptions, we make note of it. So I would say that certainly for the acute care content, it is very generalizable to children as well. Maybe not babies, because they're always a little strange and have funny.
Ambulatory is also for both.
Correct, yeah.
The nursing home one, not so much.
yes, and we just to address a housekeeping question, this presentation will be available along with the recorded webinar on CDC's Tune In to Safe Healthcare website, and you'll be notified when that is available. Typically takes a couple of weeks, and then we also have it linked to the CDC's antibiotic use and stewardship websites, specifically in the CE and healthcare professionals website for resources. At this time, we're at the top of the hour, and once again, want to really thank our speakers. I enjoyed every aspect of this presentation and look forward to hearing about U.S. Antibiotic Awareness Week and National Rural Health Day from everyone this upcoming week. Thanks again.